Hi, everyone. This is Beth Horwitz with All Chicago. Thanks for joining us today for this webinar on serving people experiencing homelessness during a pandemic. As a quick sort of housekeeping, hopefully you can see this. You'll all be in listen-only mode as the panelists are speaking with us. And so ask that you use the chat box and questions to submit your questions, and we'll hopefully have about 15 minutes at the end to respond to those questions, as well as some next steps around how we'll likely answer more questions after the fact and get them all out back to you. And with that, I will stop sharing my screen and turn things over to Steve Rothschild from Rush to get us started.
Thanks, Beth. Thank you all for joining us as we talk about our initiative around serving the homeless during this COVID crisis. So I'm going to just kind of tee this off by saying who we are, how we got together, and what we've been doing. So this began around March 13th as one shelter who you're going to hear from and one provider who'd been working together for 30 years. The state had about 200 cases then, and we were starting to see some people going to the hospital. We had a challenge of this shelter in terms of how are we going to get people further apart? How are we going to provide care if our volunteers couldn't go into the shelter, and so on. And very quickly in our conversation, we realized we weren't going to be able to solve this as one shelter and one provider. So we began reaching out to our networks of colleagues of other shelters and so on. And very quickly, this grew into we had daily phone calls that consisted of up to 40 people from a variety of hospitals, healthcare for the homeless providers, homeless shelters, other congregate living settings like transitional housing and substance abuse services, policy advocates, and then government representatives, most notably the Department of Public Health, but also here in Chicago, Department of Housing and the Department of Human and Family Services, Support Services. We began identifying what we were seeing on the ground and what we were trying, or what we thought we could try together to address the problem before we started seeing COVID come into the shelters and spread like wildfire in a very self-contained, very closed situation. I want to be clear at the outset that we were very much an ad hoc group. We are still an unchartered group of stakeholders who are committed to addressing these issues, but don't have a formal charter. And we have been very careful about that. We have large hospitals in this stakeholder group. Rush was the first, but we also are partnering with University of Illinois Health, UI Health, and the county system. And I think those large hospitals have made it easier to engage with the city because we are the larger institutions. We have the credibility. We also have infectious disease experts and other experts you'll hear from. But it's the community partners at the table that have the eyes on the situation, the boots on the ground. They're the front lines in this. So our approach with the city has been, this is what we're seeing and how can we help? This is what we can do. We have 5 major areas we have been working on evolving over the last few weeks. And you're going to hear about each of them in a moment. Number one is we've been trying to help the shelters respond, try to create opportunities for them to space out people by identifying new locations and new opportunities for people so that we can half the shelter population. Number 2 is beginning to be able to screen people for ILI, influenza-like illnesses, possible COVID infections, and being able to test and isolate. Once we have people who are identified in that way, we have 2 other initiatives. One is standing up an isolation unit in a hotel so that until we have test results, People who are symptomatic can be isolated from the rest of the homeless population, but also receive the necessary wraparound and support services. And then for people who are confirmed as COVID positive, who test positive, to be able to move into a congregate unit where they can stay until they have fully recovered. And that's based on them not having some illness that requires hospitalization, to either be coming out of the hospital or having a milder level of illness. And then finally, and most importantly, probably serving as a clearinghouse with each other as a resource for problem solving, sharing information, and so on. So before passing this off, I want to just highlight how we were able to do this and what made this work. And this is a pretty, my opinions of what we've done right and how it's been able to get off the ground. First off is we've been an open table. If someone at the table knows somebody else who can help in a meaningful way, we bring them in. We're not vetting people. There's not a membership. It's just, you got something to offer, come on to the table. It's especially, important to get all the stakeholders on the phone. As I said, we're on the phone every single day, 7 days a week at 8 o'clock with all stakeholders. The clinical providers are on the call, on a second call at 3 o'clock every day. And then other subgroups are meeting at other times. But at least once a day, we've got all the stakeholders at the table. We have a consistent time. We try to follow a fairly consistent agenda and keep the conversation moving. So we're done with updates, problem solving within an hour. We've created a web platform, which was basically just Google Drive, free, easy, and any documents, any policies and procedures, things we got from IDPH or the Chicago Department of Public Health get forwarded there. As we develop policies for screening, those go in there. The notes from the meetings go in there. It's a one-stop shop for information. We have information on there about how people can make homemade masks that meet CDC requirements. Anything that people can find helpful, you can find there. We have also kind of built additional tech support through a Slack channel, which allows the entire group to get messaged at one time, or individual groups, the infection control group, the shelter providers, the students, to communicate offline without using email. The other
Steve, sorry to jump in on you. If you have a last wrap up, otherwise we have to move on over to Richard.
Yep, thank you. Everyone on this call is committed, knowledgeable about homelessness. There's high concern. I think that's what's held it together. It is hurting cats. You're going to need to really stick to some facilitation rules to keep things moving. But otherwise, that's how we've been doing this. Richard, I'm going to toss to you.
Great. Thank you, Dr. Rothschild. Can everybody hear me okay? Great. Well, as Doctor mentioned, it was around a month ago exactly when we reached out to Rush, who we've been partnering with for, as you mentioned, about 20 years here, Franciscan Outreach. And I only speak on behalf of Franciscan Outreach today. However, I do represent a handful of other service providers that have been participating on this call on a regular basis. And as Dr. Rothschild mentioned, we've continued to steadily grow over the last few weeks. And where we initially started out as a group of 6, now we are up to almost, I think, over 40, probably even beyond that. So just to kind of give you a little bit of a history as far as how this kind of occurred, as I mentioned, I did reach out to Rush, who had been our partner, obviously and Lawndale Christian Health Center as well, as our first point of contact in trying to reach out to see what could be done to try to prevent or mitigate any potential widespread within our congregate living facilities. As we began receiving guidelines from HUD, we began to notice that we were not able to implement a lot of the recommendations around the social distancing and isolation practices that they were recommending organizations and specifically congregate living facilities do. So I did feel as if we did have a tornado or headed right in our direction, and did not feel that we had the resources or the expertise to be able to properly address it. So we did began having these calls and quickly learned that we needed to bring other people to the table, including the Department of Public Health, other hospital providers, other service providers that I'm sure that were experiencing similar conditions as Franciscan Outreach. So we operate about 400 beds. All of them are of congregate living facilities for emergency shelter, mostly emergency overnight shelter for individuals experiencing homelessness. And as I mentioned, we quickly learned that there was just an inability to be able to practice the social distancing and the isolation practices. So one of the things we had talked about was how do we implement that? And we began to strategize ways to be able to decompress our locations, our programs, and try to see if we could find alternative locations to be able to send them to. We worked very closely with the Department of Family Support Services, with DPH, and within a few days and about maybe even a couple of weeks, we were able to transport a good, at least almost half of our participants over to the YMCA to be able to better establish those social distancing. So what we also received that was extremely important was just the training and education from the medical providers. Most of our staff, are not nurses. They don't have that type of expertise or experience, and we wanted to make sure that they felt comfortable and prepared to be able to deal with this crisis. And of course, at the time, it had not even been specified as a pandemic, so we were still treating it as almost as something at a lesser degree. However, we quickly knew that we needed to provide them with education, training, and the proper equipment to be able to protect themselves and also protect our guests. So we quickly then began to identify shortages right within equipment. Thanks to Rush and some of our other providers, we're able to grab and get a handful of masks, surgical masks, some gloves as well, so that we could begin at least doing some initial screening that are some of the assessment tools that were coming out. So this group has added a tremendous value to us. I, as Franciscan Outreach, and I'm sure the other providers, we would not have been able to respond in the way that we have. We would not have been able to begin isolating and separating our individuals. And one of the things that we began, talking about at an initial stage was how do we begin channeling some of our the guests that are coming to our shelters for services, so that we can make sure that we're keeping our healthy guests healthy, but those that are presenting with symptoms, or even those that are asymptomatic but that are possibly suspicious of having COVID-19, to be able to go to the locations that they needed in order to receive the required attention and the necessary testing to make sure that we are maintaining those isolation practices. So I just want to be able to just recognize, the importance of these type of groups, these ad hoc opportunities that come up, and being able for it to be open in the way that it was. We were able to invite, numerous partners, people that we felt needed to be at the table, just being open to accepting anyone that we felt would bring, value or would receive value from this group. Just having that level of openness and being able to have these calls on a regular basis, and being able to end each call with clear action steps as far as what we were going to be doing for that next day, and developing the policies and procedures, and then having them posted directly on the Google Drive and having them accessible to our staff, and being able to post them internally and spread them has just been critical in being able to do this work. So this has been just, again, a tremendous asset to their organization and to, I'm sure, other providers as well. And I can't speak highly enough of everybody that's been involved in this process.
Thanks, Richard. I think we'll turn over to you, Tom. Tom, you seem to be on mute still.
How was that?
Much better.
Okay, this is Tom Huggett. I'm a family doctor at Lawndale Christian Health Center, and I'm happy to be part of a great team of folks who've been serving folks in homeless shelters, providing medical care on the Westside for more than 20 years. Some of our clinicians are extremely seasoned, and one of them is a co-panelist, Mary Tornabini. So I'm really happy that we're here together. And Mary, you can correct me for all the things I say wrong. My job is to kind of talk a little bit about the screening process that's been happening over the last little bit more than a week or so. So what's been happening in our shelter sites really there's been some heroic efforts, especially at Pacific Garden Mission, the largest shelter in Chicago, where the nurse there, advanced practice nurse Beth Billsley, really should get some sort of public health medal of honor because she, in that congregate, very large congregate setting, was taking it upon herself to go around to the large congregate places where there are 250 men, 250, 300 men sitting in one place pretty much all day in their day room in very close quarters, and another 150, 200 women. She would go around and just kind of look to see what people's symptoms were, or ask if anybody have a temperature. And then she would, if people would come up to her, she would be putting them in an isolation area. She really delayed things at Pacific Garden Mission, but we certainly pretty much knew early on that in this very large shelter, the largest in the city, that more systematic screening needed to happen. Of course, we were working with our smaller shelter sites, training the staff there to do temperature screening at Breakthrough, for example, and also with Salvation Army. But over the last 8 days, starting on March 30th, University of Illinois, led by Dr. Stockton Mayer and Dr. Evelyn Figueroa and their crew of medical students, really helped to do daily screenings starting at 6:30, 7 o'clock in the morning, screening the folks in those day programs, up to 350 people in one screening. What they were doing in terms of screening is that they were taking temperatures, mostly ear temperatures, some oral temperatures, and our cutoff for screening was any temperature greater than 100 degrees Fahrenheit was considered a fever. We also did screening questions, and this was all student-driven, about whether a person has had a cough that's changed, shortness of breath, muscle aches, sore throat, fatigue, headaches, or any close contact with anyone that tested positive for COVID-19. Those are the screening questions, so a temperature and those screening questions. When those screening questions were administered, they were generating perhaps up to 20, probably 15 to 20 people that screened positive for these symptoms. After that screening process, they were placed, a mask was placed on them immediately, and then put it in more of an isolation area at PGM. They were then assessed by primary care providers, family physicians, family nurse practitioners, physician's assistants from Lundell Christian Health Center. And we did a little bit further screening, and I'd like to discuss that a little bit, because even though we were having up to 20 people come to us, sometimes, I'm looking at the first day statistics, we had 7 people out of those 20 that needed to be further isolated. One day it was 1 out of 17, another day it was 1 out of 14. But then the numbers of increased, our positivity increased in terms of our clinician screening. So it was 16 of 20 or so, 10 of 20, 2 of 20, and then today actually we received 8. So what we found out in terms of our clinician screening is that we have to ask for new symptoms. So we found that this was particularly important because some of the folks that we were seeing had asthma or COPD or other symptoms that might cause a cough. We also asked for new, any new sore throat or anything like that. We had to screen out people with postnasal drip, for example, or allergic rhinitis. One person we had actually had strep pharyngitis as a cause for their sore throat. So what we've also learned over these last days is that our screening threshold has become lower, if that makes sense. So as we have known that people are more in contact with people with known COVID-19, then our screening threshold has really become lower. For example, the 8 people that we saw today, 3 of them had known contact with somebody with COVID positive, and they may have had a cough or some aches. And even if they did not have a fever, that was enough for us to say, hey, we think that you need to be isolated. We also have been informed by some of the testing that University of Illinois has done for the folks that were referred to the hotel where we're taking care of 37 people right now and where I'm sitting right now. What we're also noting and comparing the people who are positive and who are negative for COVID-19 is that fever was less often noted in the negatives. Let me say that again. We noticed people who were negative for coronavirus, fever was less often noted. So that is very interesting. So if there is a fever, that is the most important screening sign that we can do. The other thing that we also do is part of our screening, and I'm coming to the end here, but we also ask about other symptoms such as diarrhea, stomach upset, or anosmia. Anosmia has not been a prominent one for the ones that we've been screening, but certainly stomach upset, and we've been actually giving out a lot of famotidine or omeprazole because people's stomachs, they have some upset stomach, which is kind of an interesting observation that we've seen. After we do this clinical screening and we consider them that, well, it looks like they need isolation because they have a high likelihood of COVID-19 disease, before they are transferred to the hotel, we need to make sure that they are appropriate for a hotel setting. And we have a series of criteria I'd like to just go through very quickly, because these screening criteria are actually really quite important to make sure that a person is appropriate for a hotel setting for isolation purposes, rather than in a hospital. So of course, if a person has severe symptoms like a temperature perhaps above 103, oxygen saturation less than 90, increased respiratory rate, increased work with breathing, perhaps even some confusion related to hypoxia, or almost feeling severe dizziness, then that person should be monitored probably in a hospital setting and not in a hotel setting where we are, we're taking care of 37 people with a kind of a smaller staff and are only able to see them clinically maybe once a day. We are not running a hospital. Other risk factors that may increase risk of rapid progression, we are also kind of excluding. If a person is using supplemental oxygen, we don't feel like that's appropriate for a hotel. Just if they're older, if they're over 70 or 80, then that would be more likely that they should not be in the hotel. History of frequent COPD exacerbations, very uncontrolled diabetes, history of alcohol withdrawal symptoms. If there's a possible opioid withdrawal and they're not interested in medication to treat opioid use disorder, we would consider that an exclusion. Of course, we are able to take people who are taking medication to treatment, but if they don't want to have it, then they're not being a person from the hotel. We do have people who have psychosis here in the hotel, but psychosis, so that's something that we just cannot handle. If a person has a personality disorder or behavior that would challenge their ability to abide by the rules of the hotel, again, that would not be appropriate. Of course, suicidal ideation.
Tom, sorry to interject. If you want to round up with a last thought or two, we have to move on over to Stockton.
Yes, I just want to say that we're really appreciating that we have these exclusionary criteria, and we also ask about mobility. So we're happy to take care of people in the hotel as long as they're appropriate.
All right, Stockton, you're up.
Sure, thank you. I'm still on my webcam, but it looks like our webcam limits are being used up, so I apologize. Let me see if I come back up again. No. All right, so my name is Stockton Mayer. I'm an infectious disease provider at University of Illinois, and I've been working with the group for the last couple of weeks, and I'd really like to thank everyone for including me, and particularly to Steve and Dave for the leadership with this project, because it's been fantastic. So I'm going to talk about three things. One is the role of the infectious disease provider in sharing expertise with multiple different partners. Two, infection prevention practices for shelters and congregate settings. And three, specific infection risk in congregate settings and who should be tested. So to address number one, work with the consultative role for infectious disease experts. I work with primarily three separate partners. One, the shelters and the staff, and specifically and more frequently with the shelters Pacific Garden Mission and the Salvation Army. I work with practitioners as well, so colleagues from Rush, UI Health, and others. and then I work with the Department of Public Health. And so I think all three partners are very kind of important, and appropriate communication channels are really important, kind of making sure that this project runs smoothly. On the shelter level, I found it very helpful to get actually into the community and visit some of the shelter spaces themselves. It's very difficult to provide infection control support without really understanding the layout of some of these shelters, with their isolation capacities and with their housing capacities are. So as an infectious disease provider, it's very helpful if I'm actually able to get out of my office and go see the spaces themselves and talk with some of the folks that are actually out there. A lot of my kind of role has been surrounding education, particularly for the shelters, clarifying guidance from CDC and from the state. And I think that the presence of infectious disease providers has been very helpful. With regards to other practitioners and other colleagues, it's been very important to just kind of share and disseminate knowledge and answer questions regarding things like PPE, perhaps clinical management. Certainly working with Tom at the hotel, identifying perhaps high-risk folks, folks that may not be appropriate for the hotel themselves. I think there is an important role for ID practitioners in that regard. And then thirdly, working with the Department of Public Health, you know, my role as an infectious disease provider is to really kind of follow their direction. The Department of Public Health here at the city level has been fantastic. The big eye in the sky, kind of letting us know the most appropriate strategies for things like testing and screening. And it's very important to have a close collaborative relationship with them. Moving on to the second topic, infection prevention practices for shelters and congregate settings. You know, I'll talk about this in just a second, but really kind of following the social distancing recommendations the best we can is probably the most important thing, and partially because some of the lack of other things like maybe universal testing. You know, certainly if we had universal testing, things might be a lot easier, but we don't necessarily. And so getting to the social distancing as much as we possibly can is probably the most important thing. I realize that, and one of the biggest difficulties in the shelters is that there's really not a huge capacity for placing people in individualized rooms, so moving bunks apart, maybe adjusting meal times. I think have been strategies that I've seen through various other shelters that have been very good. One of the things that we've done, and with the help of David Ansel and our Rush colleagues, has been get masks out to all the shelters. That's been very important. Again, we don't really have the capability for testing everyone. What we have seen with the testing that we've done is a lot of like asymptomatic carriers, people that are PCR positive that have been asymptomatic. And that's one of the main reasons that masks are very important, not necessarily for protecting oneself, but from protecting others from you. And it's very important that we educate our residents and our staff on the importance of masks and getting our hands on some if we can get some. I think that one of the other points I want to make before moving on to the last point is you can't manage the infection if you can't manage the comorbidities. And this is something that Tom and team is doing a great job of doing, making sure that substance use disorder, psychiatric comorbidities are well managed. We can't keep people isolated and sheltered, you know, without greater restrictions or restrictive policies if we're not managing some of these other things. And finally, the specific infection risk in congregate settings. You guys all know that this is a very high risk population. And I would argue that shelter populations are some of the highest risk, particularly because there's not individual rooms in which to isolate folks and keep them. So everyone is living together in the same space all the time. So it's important to understand that. Specific areas in which to test or what are the indications for testing? Unless you have real access to testing, I would say I would let your Department of Public Health help guide testing strategies. If you found one through screening processes, there are likely a lot more. And so making sure people are wearing their masks, educating folks, and then working with the Department of Public Health to come up with a testing strategy is very important. That's it.
Thanks, Sachin. Over to you, Mary.
Can you hear me okay?
Yeah.
All right. My name is Mary Tornabene, and thank you very much for including me. It's an honor to be part of this panel, and of course to work more with Tom. I'm a family nurse practitioner with Heartland Alliance Health, a federally qualified health center, healthcare for the homeless grantee, and integrated system of care. The connection between homelessness and health, both physical and behavioral, are coldly logical. Poor health causes homelessness, and homelessness causes poor health. Recovery is more difficult when a person's experiencing homelessness as well. However, our population has multiple drivers of high risk for their health. Our homeless neighbors are impacted by chronic medical and behavioral health problems, infectious diseases, acute illnesses, trauma, and exposure to elements. They live in and frequently visit congregate settings, including shelters, recovery homes, soup kitchens. These all increase their exposure. They're an older population. They have limited mobility and a life expectancy that is 17.5 years shorter than what is recorded for the general population. There's limited ability for homeless to follow public health advice, to stay home, social distance, and even to wash their hands. They're isolated from mainstream response systems, have less access to even charge their phones, and are more likely to be turned away from services than our housed neighbors. Shelters are closing. Many shelter systems are largely staffed by a volunteer force over the age of 65, and during this crisis, more volunteers are staying home, leaving fewer beds and more rough sleeping. When a person experiences homelessness, is engaged in whole person care in a safe environment, with acute sensitivity to their needs and life experiences, with health teams that are able to restore and maintain dignity, we can engage them in their personal health plan and recovery. Patient-centered teams for our clients generally include primary health care, behavioral health services with psychiatry, therapy, and substance use treatment, case management, transportation assistance, housing, and adherence coaching. We also know that when our program participants experience a crisis, their life can become more desperate and consequences more dire. But when wraparound homeless-specific services are in place, crises can be managed and stability can be maintained. I want to tell you about one shelter system that I work with and how they are addressing our present COVID crisis. Journeys the Road Home is a not-for-profit agency that provides both shelter and a comprehensive spectrum of social services to the homeless and those at risk of becoming homeless in 37 towns in the north and northwest suburbs of Cook County. Heartland Alliance Health has been the healthcare partner of Journeys for the last 18 years. In addition to care in our health centers, I provide on-site clinic weekly, and we have psychiatry on-site monthly. Journeys has a PADS emergency shelter program that provides overnight shelter for the homeless. It is scattered site, and there are 2 to 3 different churches hosting PADS each night. The PADS sites are largely staffed by retired volunteers. When Illinois began to see an increase in COVID, overnight volunteers started canceling. By the end of March, none of the overnight sites were able to open, leaving 100 persons on the street each night. Journeys received a directed donation, which allowed them to provide hotel rooms for their participants. They're using 2 hotels which share the same parking lot. And Journey's wonderful work continues. Homeless-specific services, including mental health, case management, counseling, housing, substance abuse counseling, and transportation are provided by Journey staff. There's food delivery twice daily. Telepsychiatry and telehealth are available for Heartland Alliance Health. The staff from Journeys rounds on the participants frequently. The clients must follow the hotel rules, Journeys rules, and the Illinois state COVID restrictions. COVID-19 screenings are provided twice weekly by Heartland Alliance Health. Case managers were trained and assessed symptoms with each other, or with each encounter, on the telephone or in person. I obtained a Google phone number and gave instruction for patients to call me directly if they experience symptoms consistent with COVID, and we have a plan in place to monitor the participants when they become ill. So far, all are maintaining their health. It's unlikely this population has been without access to alcohol and opioids, but we do have a substance-specific plan in place for when that does occur. The most amazing thing is happening. I have been caring for these people for 20 years, and for some, this is the most lucid I've ever seen them. I'm having conversations with patients that I never thought was possible. Our homeless neighbors have been in a hotel for 16 days, and they have unprecedented privacy and security. They have their own keys, which is something they haven't had in a long time for many. They stay in their rooms better than I ever thought they would, but this is due to the consistent homeless-specific services provided by the staff of Journeys. Thank you.
Thank you. We'll now turn it over to Megan and the CDPH folks.
Hi, everyone. Can you hear us okay?
Yeah.
Okay, thanks so much for inviting us to join us today, and thank you to this team who have been incredible partners and really, in many respects, thought leaders in helping the city organize our response to COVID-19 among people experiencing homelessness. Well, Nise and I are going to try to practice some social distancing even as we're speaking with you today, so we'll share the screen a little bit here. My name is Megan Cunningham. I'm the Managing Deputy Commissioner for Strategy and Development at the Chicago Department of Public Health. I'd like to share with you just a little bit about the city's overarching response to COVID-19 among homeless populations. I'll invite Dr. Jasmine to join me throughout to add some commentary about the work that we're doing around case investigations and other mitigation approaches. Our broad goal for this population is to develop a citywide system to prevent transmission of COVID-19 within congregate settings and encampments, and to provide compassionate care for people who are experiencing homelessness. And the three buckets of work that we are pursuing to really make that goal real are first, prevention. So taking steps to stop or slow the spread of COVID within congregate shelter settings and encampments. And that looks like having the Chicago Department of Public Health and Dr. Jasmine playing a critical role in developing guidance and screening tools that allow shelters and outreach workers to reach their populations appropriately and to manage individuals who may become symptomatic while they are in the shelter setting. We've also been working with our colleagues at the Department of Family and Support Services to decompress our shelter setting. So recognizing the importance of social distance and the need then to create additional shelter spaces. We've been able to bring multiple new congregate sites online in just the last week or so that allow us to create more physical distance in our existing shelters and maximize this new shelter footprint that has now become available. We're also working to provide personal protective equipment and thermometers for shelter staff and outreach workers. I apologize, it looks like you may have lost our webcam. We have a bit of a spotty internet connection here, so do bear with us. Can you still hear me though?
Yeah, your audio is great.
Okay, thanks. So we were very pleased through a partnership with Project Hope, which donated a large amount of face masks and face coverings last week, and in coordination with a small army of volunteers out of Rush University Medical Center to create kits of PPE that were then delivered or picked up by our shelter partners. So that is just a first bolus of this critical PPE, and we are continuing to seek a sustainable supply so that can continue to flow. We know how important that is when we mark this call. We're also pursuing a strategy to provide supportive housing for people at high risk if they were to contract COVID-19. So this would be kind of a new tool in our toolbox, rather than waiting for people to become symptomatic and then responding. Recognizing the extent of community spread that we are seeing today, we're interested in looking at options that would allow us to actually identify individuals who are at high risk, those over the age of 60 or those who have underlying medical conditions, and remove them from the congregate shelter setting, providing them with appropriate and supported individual units, particularly during the peak of this COVID response. So that is a new model that we are exploring actively here, and we hope to bring online in the coming days. So all of that's in that kind of prevention bucket. The next body of work is around identifying people who have symptoms and their cases and close contacts through deep screening, testing, and investigation. Dr. Jasmine, do you want to talk a little bit about the screening and testing approach that we have in place?
Yeah. So the initial screen that was developed was made in mind for places that might not have thermometers. So it talks about subjective symptoms. One of the main supplies that we don't have is thermometers. So I understand that it's important to know the actual temperature, but with what we had, we were asking about subjective fever. So once someone does screen positive, and we know we're working with staff members in the homeless shelters who don't have a medical background, we provided them a contact for them to reach out to a member of our Medical Reserve Corps to ask to help them determine whether or not the symptoms that they are presenting is something that warrants them to be warrants them to go to isolation. And if there are any questions about underlying conditions that may place someone at increased risk for having severe illness, the Medical Reserve Corps member would also be available to answer the question. And so once the person is determined that they have to go to receive testing or isolation or quarantine, then they would actually have to go to a medical facility to get testing. For patients who are already in the hospital and are being discharged either from the ED or from an inpatient setting, and if they are homeless, it's not appropriate to send them back to the homeless shelter. So we ask discharge teams to fill out an intake form that is then reviewed to make sure that they're still within that 7-day window after they were first diagnosed to see if they qualify to go to an isolation facility. And the type of isolation facility we do have live right now, it requires the patient to not have too many comorbidities. It's very limited. And so I know with this population, that's not suitable for the majority of people. And so we're working to also bring online another facility that is able to provide the wraparound services.
Thanks very much, Dr. Jasmine. So Dr. Jasmine was just alluding to not just our strategy for identifying individuals who have symptoms or are confirmed to have COVID-19, but also our strategy for then responding to remove people from the shelter setting and to allow them appropriate places for quarantine and isolation. And that's where I need to say, again, a huge thank you and a debt of gratitude to our partners at Lawndale Christian Health Center and at A Safe Haven, who have stood shoulder to shoulder with the city to stand up these pilot settings, to really try to learn rapidly about what sorts of protocols and supports are needed in order to deliver that kind of compassionate care that we discussed earlier, and then to allow us to have a base to build from, as we know that while this epidemic continues to spread within the city of Chicago, the demand for these kinds of housing solutions will only grow. And so part of what we are excited to talk to folks on the call about today are what is that next phase, as we need to now take what we've learned and bring it to some kind of scale. What does it look like to call upon the people who are participating on this webinar today and those within your network to say, please stand with us to conduct screenings within shelters. Please stand with us to be a trusted resource of medical service delivery in these shelter settings when times get hard over these next couple of weeks. Please stand with us to think about operating an isolation setting where we can bring people who need to be removed rapidly from that shelter setting and given a safe place to recover. This is going to be a hard couple of weeks here, and particularly for people on this call who feel deeply devoted and called to service in support of our persons experiencing homelessness. And so we thank you for the resiliency that you've shown so far, for the dedication that you've shown so far. Now we will continue to ask of you to think with us about how we grow this continuum of care, how we wrap our arms around this population in the weeks ahead. Thank you.
Thanks. And then to David, if you want to add to that.
Yeah, I'm bringing this home, everyone, closing this up. David Ansel on general internal medicine, primary care doctor, and lead Rush's health equity work, and sit on at our command center on the hospital side as we respond as a hospital, but also working on this community side. If you think of the surge, you think about a lot of what we hear on the news is ventilators and ICU beds, but there's a surge in the community. And if we don't treat the community surge, we can't treat the hospital surge. The community surge is actually the most important surge to treat because it's going to really decide who we are as a city and how we're going to get through this. This epidemic is unprecedented in my experience, and I think we're all flying a little bit by the seat of the pants. Critical to this effort was setting a table with everyone at the table. And because we are able to actually think better as a group, and the table that got set first with Rush and Franskison needed everyone else at the table. We thought about this as a Westside focus, but it's clear as we move on that this is a citywide focus to Megan's conversation. And it's a table in which, as Steve said, everybody's invited. There is a bias to action that's been critical to this work. as problems have arisen in the morning, we've tried to solve them by the afternoon, and to ask for forgiveness around this. The example I can give is when we had an outbreak in one of our congregate shelters, we realized that outbreak and people were gotten tested, and this is actually before we got the test back, or right about the time, we realized that the only safe infection control approach would be to mask everyone in the shelters. Well, how do you mask everyone in 97 shelters in Chicago, and how do you do it in 24 hours? But we did it through the partnership with the City of Chicago and Project Hope, medical students, and everyone else. We were able to distribute this PPE to the shelters within 24 hours. I'd like to say another thing about this is about volunteering discretionary efforts, about looking in the mirror, all of us, and saying, what more can we do to get the outcomes we want? The other thing about this is we've moved along this, we realize there's got to be a standard of care for public health in this crisis, at least sufficient care. And as we move along, it's really important that we be aligned with the city in defining what the standard of care is. Some of these situations are hard when you have outbreaks in a shelter, knowing who should be tested, how do you isolate. We know the weeks ahead are going to be harder. And we actually think the lessons from this are going to help us when we're dealing with the gaps in the African American and Latino neighborhoods with higher mortality. What we're learning from this vulnerable population applies to all vulnerable populations. And there's no way for the health department or any of us by our single institutions to do this alone. This has to be a mass community effect, offensive in which we're all in. There are pearls. You know, we talk about clinical pearls on a hospital when someone has a case in a clinical pearl. There are human pearls. Tom Huggett, he's a human pearl. He starts his program at a hotel and then stays overnight. So he's there. He's also a pretty funny guy because one day he made this joke about rush paying for, Pacific Garden Mission to be screened. I thought that was just the funniest thing I'd ever heard. But I didn't know it was a joke. But no, it's just terrific partnership we have here, and everyone's stepping up, and that's what we got to do in a moment like this. In the end, the biggest lesson here is we need safe, permanent housing for the homeless. People can have a key, what Mary said, a key, a place they can call their own, and we're not going to stop at this epidemic. We are going to really push our city to be the model for the nation for permanent housing for the homeless. I'm going to stop there. And I think we want to have time for some questions. By the way, this is the first time I've ever been under 5 minutes in my life. So
I will again share my screen with folks. There's an email address you should now be able to see. So to the extent that we're unable to answer all of the questions, or if you think of others, feel free to share those in. So that we can make sure to respond. And if we're not able to answer all the questions that have come in the chat box, we will get back to you with both a link to the Google Drive that is available, as well as answers to these questions. So as a starting place, someone asked the question of whether we're involving people experiencing homelessness in meetings and getting their input on how things are going and what is needed, which I'm not aware that we are, but sort of curious to share with folks and hear what you guys think about that idea or what that would look like.
Yeah, this is Richard. I mean, I think having individuals with lived experience being included in any conversation is always extremely important. We have been going back to our shelters, and obviously, including staff and guests within any changes that are taking place, the biggest change being around the screening process and trying to get their feedback and just assurance that we are doing these practices not to screen people out, but to make sure that we are trying to keep them healthy and safe and try to get them connected to the best care. But I would be very open to including individuals.
This is Tom from London. We have been kind of talking with our folks that are coming to the hotel, especially from PGM, and one particular poignant remark was from one gentleman who said, well, if I screen negative, does that mean I'll have to go back to where a lot of people who are positive are living? So I think that type of feedback is so important. to echo what Dr. Ansel said about finding permanent supportive housing for folks who really need it and really need proper isolation housing.
This is Stockton Mayor with infectious disease. I work out at COIP with Dave Jimenez and his crew, and he's been asking folks, and a lot of our homeless or people experiencing homelessness, those clients are also dealing with opioid use disorder. And he's been asking them about if they had to be isolated or they had to be quarantined, what would be important to them. One of the things that they repeatedly say is that they'd be cool with it as long as they're getting treatment for their opioid use disorder, Suboxone, et cetera. So that is an important aspect, I think, to these programs, and something that has been endorsed by the community as well.
Great, here's another question. Are there different or additional plans for youth and families in shelters? With a volunteer from Lurie Children's to see how they might be helping with that.
This is David Ansel. At the Safe Haven, we hope to open this week a 115-bed COVID positive unit that will be able to accommodate men, women, and some families, or some rooms that can be used for families. I do think this is the painful part of this, that we've got so many people caught up in the epidemic of homelessness that the epidemic of COVID just creates these complications. But we will have space for them at a Safe Haven. We're hoping that opens on
We'll leave you in suspense. We're hoping it opens soon, but we're not exactly sure what day yet, unless CDPH has an update for us. But I will say, as a follow-up on that note,
make that as really, sorry, this is Megan at CDPH. We're working aggressively to bring that housing solution online, throughout the day today, hopeful that we will be able to begin intakes tomorrow. The only additional point on addressing, women and families, and I appreciate the question from our colleagues over at Lurie. The city, in an extension of its decompression efforts, is creating a new facility, I think using some of our YMCA space, that will be dedicated specifically for women and children. This will not be an isolation facility, but it will be a new accommodation that allows appropriate social distancing. And there may be some ways in which we can connect our colleagues at Lurie to that new site to provide some of the supports that I know you're interested in offering.
Sort of another question on another population, a question of, is there a plan for screening in the unsheltered population of people experiencing homelessness?
This is Steve. This has come up through one of our partners, the Night Ministry. They have been reaching out and doing some screening at various encampments. We have not yet developed a systematic screening process or testing process there yet, but they have been making the rounds and trying to connect people to the services we're talking about. But so far, that's the next step.
The City of Chicago has also been working with the Chicago Coalition for the Homeless and other partners to ensure that our encampments have appropriate access to hand hygiene and portable wash stations. So those hand hygiene stations have been delivered to our larger encampments, and the washrooms are coming online, I think, in the next day or so. We are working with outreach case workers to try to supply them with PPE. And, as others have said, working on what a screening and then intake process for quarantine and isolation would look like to serve those encampments.
We've just gotten an update. Portable toilets were delivered today at 12 sites. So that's from the coalition in live time. Another question about how the group's thinking about diverse language needs or challenges in staffing, et cetera, in meeting the needs of people in these many different layers of care.
This is Tom from Lundell. Yeah, I'm glad you asked that question, because this is a challenge for us. not just Spanish speaking, but other languages, especially Polish, we're running into that issue too. So I know we used to use Polish American Association for some translation efforts, but yeah, we would really love to have those resources.
The city also has access to Language Line, and if we need to talk about ways to leverage that in service of some of these quarantine and isolation sites, we can certainly do so.
Another question's come in about, you know, the dynamic of people experiencing homelessness may not have access to cell phones or the internet, and what efforts are being made to keep people up to date on how to avoid infection, and how are they being updated about essential resources available to them.
From the Department of Public Health side, we've been working with our Department of Family and Support Services to conduct regular webinars with shelter operators and individuals who work in the encampment settings through outreach to share with them the most updated guidance and to work with them on strategies to deliver that then to the shelter population that they serve.
This is Tom from Lawndale again. We have been working with some of the drop-in sites, especially Breakthrough Women's, Breakthrough Men's. So that is a way for people who don't have a phone and just drop into a drop-in center to actually get their temperature taken, be educated about hygiene proper processes, and get a mask.
As another thing that's come out of this group, I know there's some handouts that were created by, now I don't remember what, somebody at one of the partner institutions in largely visual around the best recommendations right now that we're hoping to get out to all of the shelters in the next couple of days once the Kinko's order comes in, as another attempt this group has thought of in both English and then hopefully translated into Spanish to get to folks who are currently accessing services. Thinking also towards both Megan and David's call to action that were put out there. Just wanted to share a piece of feedback that one of the other members of the group put into the chat, which is to say, besides the much needed medical assistance, this group has provided a sense of security for shelter providers. They provide a level of support that enables us to function in this crazy pandemic, and how grateful the providers are for the support of this group. And just to say to all of our medical providers out there who may be able to flex into this space in other parts of the city or county, and I believe we have some folks from elsewhere in Illinois, just to say how much the work of this group is meaning to our shelter providers that are already getting that support. And I think on
just for one second, Ansel. So this is a critical point. You know, we're all flying a little bit by the seat of our pants. Everyone needs all the help they can get. The shelter providers really have not been in the medical care business like this, and they really do need any medical support is helpful. So when I said voluntary discretionary efforts, we have places in Chicago on the north side, on the south side, in the suburbs, statewide. We really need those medical providers who may not have even ever been in this business before to step up and find ways to connect in with this very vulnerable network and community, because even small things make a really large difference. What we've been able to find is we can network across our various spaces and find the answers to questions pretty quickly, and it provides a large degree of reassurance to our shelter providers in real time.
Great, thanks everyone. I'm mindful of our time. I know we did not answer nearly all of the questions that have come in, and so we will make sure to review these. As was mentioned, the group talks to each other twice a day, every day, if not more, so we will get answers put together quickly and get back out to everyone who's on the webinar, along with a recording and a link to the drive and some other of the materials that we've mentioned today. And just thanks everyone. I know it was the last minute, but really appreciate all of you joining us today, and hope to see more of these initiatives showing up elsewhere in the city and around the state. Thanks everyone.
Bye-bye.
Thank you.